Greetings, I'm Dr. Jong-Chul. During implant placement, there can be many different complications. During sinus lift, there can also be different complications. Therefore, you need to be aware of complications that have high possibility of occurring, and you need to reflect that into your treatment plan. In this lecture, I'm going to talk about various complications that can occur during sinus lift and ways to address these problems. The contents of today. There are many complications that can occur during sinus lift. There can be intraoperative bleeding. The graft material can migrate within the sinus. It can be impacted, or the implant can migrate into the sinus. When you do crestal approach, membrane can be perforated. There can be many different complications. When you do lateral window approach or crestal approach, there can be different complications as shown. More so than the crestal approach, when you do lateral approach, there can be more complications. Today, I'm going to talk about complications that can occur frequently. I'm going to look at the cause and ways to address these problems. First is intraoperative bleeding. Let's look at the cause. This occurs more during lateral window approach, more so than crestal approach. Bleeding can occur when incision is made on the soft tissue or when window is formed during lateral approach. Also, bleeding can be caused if the patient has systemic disease that can cause bleeding. As you all know, on the exterior wall of the sinus, anastomosis is formed between posterior superior alveolar artery and infraorbital artery. In other words, there's intraosseous anastomosis. And there's extraosseous anastomosis as well. The intraosseous anastomosis is normally 19 millimeters superior from alveolar crest, and the extraosseous anastomosis is approximately 23 millimeters superior to the alveolar crest. So let's look at extraosseous or soft tissue bleeding first. This occurs frequently when vertical releasing incision is done. If you do this too deep, extraosseous artery can be damaged, causing bleeding. This occurs quite frequently. This patient is female patient in mid-50s. The residual alveolar bone was very limited, and therefore window approach was used to place the implant. Vertical incision was made, as shown in the superior area. A very severe arterial bleeding occurred. As you can see, there is a severe bleeding around the surgical site due to arterial damage. And the first thing you should do in this case is to apply pressure. You can use gauze, or in emergent cases, you can just directly apply pressure. Using these two methods for 2 to 3 minutes may lead to stop in bleeding. If it does not stop, the best way to do is to do electrocauterization in the area of bleeding. This is the most simple way. At times you can do suture. However, the most simple way is to use electrocauterization. Next, I'm going to talk about bleeding within the bone. In other words, in the case where there's damage to intraosseous artery. Upon window formation, if this vessel is damaged, bleeding can occur. Intraosseous artery is 19 millimeters superior to alveolar crest. It may vary depending on the patient and the condition. It can be more inferior, and in that case, bleeding can occur. Please refer to the right side. In the window approach, you can see that artery passes through the exterior wall of sinus. If you can see the vessel, you can form a window avoiding this area. If this can be avoided, you'd be able to avoid bleeding within the bone. Intraosseous artery can exist in 4 different areas as shown. In other words, it can be within the exterior wall or it can be within sinus. Rarely, it can be exterior to the bone. If you look at the literature, the artery can be within the bone or towards the sinus, or very rarely it can be on the outside of the bone, superficial. If you look at the literature, in most cases, intraosseous artery exists, followed by intrasinosal artery, which is quite rare. And very rarely there exists superficial artery exterior to the bone. The artery normally is 19 millimeters superior to the alveolar crest. However, if there is a lot of alveolar bone resorption, or if the artery is more inferior than expected, when you form a window, bleeding can occur quite frequently. A lot of dentists do not prefer the window approach because they fear that there might be severe bleeding. That's why they don't like the window approach. Intraosseous artery is different depending on patient. If you look at the literature, the vessel can exist 9 to 10 millimeters superior from the sinus floor. If you look at various literature from the sinus floor, it is 9 to 10 millimeters superior. If you look at the literature from Korea, from the alveolar crest, in the case of premolar, the intraosseous artery is 23 millimeters superior, and in the case of first molar, 16 millimeters superior. Second molar, around 15 to 16 millimeters superior. From the sinus floor, the intraosseous artery exists 11 to 12 millimeters superior in the case of first and second molar. Therefore, when window is formed, the height of the window should be within 1 centimeter. In my opinion, 6 to 7 millimeter is recommended to avoid damaging the artery. This is a literature from Korea. From alveolar crest, you can see that it is most frequently 15 to 19 millimeter. This is a 60-year-old male patient. I'm going to place implants on both sides using window approach for the upper posterior area. The overall residual bone is very limited in quantity, and if you look at the CT on the right side of the sinus, you can see the intraosseous artery. During window approach, you can see the vessel here. There's no choice but to cut through and do window approach in this case. There's no other way to do it. You come across these cases quite frequently. If you assume that there's going to be bleeding during window approach, then you'd be much less caught off guard. The easiest way to do it is to do electrocauterization using Bovi. This is the way I do it. This is the same patient. This is upper left. On CT, from alveolar crest, you can see that the vessel is quite superior, and clinically, it was approximately over 2 centimeters from the alveolar crest. In this case, when you form a window below that, you can do it much more easier. Sinus can be lifted without concern for bleeding. Even if it is the same patient, the intraosseous artery position may differ, so you need to be aware. If necessary, you need to take CT and observe the intraosseous artery ahead to avoid bleeding during surgery. This is after surgery, and this is after implant placement. Now I'm going to talk about how to control bleeding in the case it occurs. The easiest way to do it is to apply pressure. Next, you can suture the vessel or do ligation, but this is not done frequently. When applying pressure, you can use hemostat. This is also a good way to do it. The next most frequently used way is to use electrocauterization. If you look at the literature, approximately 71%, the vessel was smaller than 1 millimeter, so it's quite small. In this case, even if there is damage, you can stop bleeding very easily, and it can stop upon pressure. However, if the vessel is over 1 millimeter, bleeding cannot be stopped easily with just compression. In this case, you need to use other methods. If the vessel thickness is quite large, if it is damaged, severe bleeding can occur. This can be observed in young patients and patients with thick bone. Ways to stop bleeding. The most frequently done way is to use compression. Using gauge, you apply pressure for approximately 3 minutes, so sufficient amount of time is spent. You can use hemostat agent like Bosman to help stop the bleeding. Once bleeding occurs, you use the gauze to do packing and apply pressure. If you do it in a rushed manner, you may remove gauze packing very frequently, so you need to set the time 2 to 3 minutes, give it sufficient amount of time, and apply pressure. Next, I'm going to talk about bleeding within the bone. You can use various tools and compress the bone like this to stop the bleeding. This is called bone compression method. This is applied when a vessel is within the bone. If the vessel is exterior to sinus or interior to the sinus, bleeding cannot be stopped. The next most frequently used way is to do electrocauterization using Bovie. If you know how to do this, you'll be able to stop bleeding very easily. This method can be applied for all 4 categories, and it's quite useful. You compress, and if bleeding continues to occur, you can use electrocauterization to simply stop bleeding during window approach, so you don't need to have great fear about bleeding. Let me give you an example. This is a male patient in mid-60s. In upper left posterior area, window approach was done. On CT, you can see that there's intraosseous artery here. After observing CT, you need to diagnose the artery ahead before surgery. This is done very frequently. During window approach, you can see the vessel with your own eyes. In the end, compression was done. However, even after 3 minutes of compression, bleeding did not stop sufficiently, so Bovi was used for electrocauterization. After actions were taken to stop bleeding, sinus lift was done in the traditional manner, bone graft was done, implant was placed. This is approximately after 2 years after final prosthesis delivery. You can see that it is well maintained. Next, I'm going to talk about graft migration within the sinus. After doing bone graft, this should be maintained within the sinus membrane. However, at times graft material pushes through the membrane and goes into the sinus. In the case where bone graft is excessive, or if sinus membrane has been perforated, the graft material can be migrated into the sinus, and this can occur quite frequently. In the case of this patient, upper right first molar area, crestal approach was done to place the implant. If you take a closer look, on the right side, the bone graft is quite superior. The implant was placed by a different dental clinic. The residual alveolar bone was approximately 6 millimeter, and I decided to wait and observe. During final prosthesis, you can see that the bone graft is gone via the middle ostium. Next, I'm going to talk about the case where implant migrates within the sinus. So, implant within the sinus. A more detailed explanation will be provided in the next section. In the case the implant falls within the sinus, there are 2 cases. After window approach or crestal approach, when you place the implant, depth control might not have been done properly. In those cases, implant can migrate into the sinus. Another case is where the bone is very soft, so it can fall easily into the sinus. This is male patient in mid-40s. The residual alveolar bone on the right side was quite limited. Window approach was to be done to place the implant. However, during implant placement, depth control was not done properly and it migrated into the sinus. In this case, it's very troubling. Caution was taken to remove the implant in the sinus. And in order to provide a safer treatment, the bone graft was done. I waited sufficiently. After 5 to 6 months, I did secondary surgery. 2-stage method was used to place the implant and prosthesis was delivered. Next, I'm going to talk about membrane perforation during crestal approach. When crestal approach is taken, membrane perforation at times can occur. You can see this quite frequently when malleting is done on the sinus floor using Sommer's osteotome, which is the conventional way. You can take 2 methods to rectify the issue. During crestal approach, if membrane is perforated, if possible, you need to use lateral approach to repair the sinus membrane, which is torn, do bone graft, and then place the implant. Or if you're less confident about it, you can wait 3 to 4 months, and after sinus membrane heals completely, you can do crestal approach or window approach to place the implant. Fortunately, with the introduction of CAS kit, there's a very rare case of sinus membrane perforation during crestal approach. The possibilities are really rare. Osteotome was used for crystal approach for this patient. In number 26, osteotome was used. When this was used, the alveolar bone height was irregular and sinus membrane was perforated. Immediately, window approach was done, sinus membrane was repaired, bone graft was done, and implant was placed. This is post-op image. During sinus lift, there can be many complications. Most common of those is bleeding. Bone graft can migrate into the sinus, or the implant can fall into the sinus. Recently, with the introduction of CAS kit, when you do crestal approach, membrane perforation can be avoided in most cases. However, during crestal approach, membrane can be perforated, albeit extremely rarely. During implanted treatment, especially during sinus lift, there can be complications. Careful treatment plan and clinical inspection needs to be done. Thorough inspection needs to be done, and prevention is the best policy. Yet, there are complications during surgery. You need to be aware how to respond to them ahead. See you next time. Thank you for watching. Thank you.